The initial management of sepsis and septic shock hinges on prompt, aggressive resuscitation, yet the rules of engagement have become increasingly nuanced. The Surviving Sepsis campaign emphasizes an hour one bundle as the standard of care, which necessitates obtaining blood cultures before antibiotics, measuring lactate levels, and administering broad-spectrum antimicrobials immediately. For patients demonstrating septic shock or hypoperfusion, indicated by hypotension or a lactate level greater than or equal to 4 millimoles per liter, rapid fluid administration is critical. However, the traditional mandate of delivering 30 milliliters per kilogram of ideal body weight within 3 hours is now viewed as a weak recommendation rather than a rigid rule. Modern best practice emphasizes a dynamic assessment of fluid responsiveness. Clinicians are encouraged to use methods like a passive leg raise or point-of-care ultrasound after an initial bolus, ensuring that fluids improve perfusion without causing the harm associated with volume overload. Once the decision to resuscitate is made, the specific type of fluid selected can significantly impact patient outcomes. There is a strong clinical shift away from 0.9% sodium chloride, or normal saline, in favor of balanced fistoloids such as lactated ringers or plasmolite. Normal saline contains a supraphysiologic concentration of chloride, which can precipitate a non-anion gap hyperchloremic metabolic acidosis. This acidosis is not benign. It can impair renal perfusion and increase the risk of acute kidney injury. Evidence from the large secondary analysis of the SMART trial underscores this, demonstrating that using balanced crystalloids results in a lower incidence of major adverse kidney events, including death or the need for new renal replacement therapy, compared to saline. When hypotension persists despite adequate fluid resuscitation, the focus shifts to vasopressors to restore organ perfusion. Norepinephrine remains the undisputed first-line agent due to its potent alpha-1 adrenergic effects that cause vasoconstriction, combined with modest beta-1 effects that support cardiac contractility. This profile effectively raises blood pressure with a lower risk of tachyarrhythmias compared to dopamine. The standard target is to maintain a mean arterial pressure, or MAP, of at least 65 millimeters of mercury. Targeting a higher MAP of 80 to 85 does not offer a mortality benefit, as shown in the Sepsis PAM trial. If the target is not met with norepinephrine alone, vasopressin should be added as a second-line agent at a fixed dose of 0.03 units per minute to reduce the total norepinephrine requirement. For patients who remain in septic shock with an ongoing need for vasopressor support, the underlying physiology may involve critical illness-related corticosteroid insufficiency. In these cases of refractory vasodilation, guidelines recommend the administration of intravenous corticosteroids. The typical regimen consists of hydrocortisone dosed at 200 milligrams per day, either as a continuous infusion or divided doses every 6 hours. Landmark trials such as Adrenal and APRICOS have demonstrated that this intervention leads to a faster resolution of shock and shortens the duration of vasopressor therapy. While this approach is vital for stabilizing the most critically ill patients, clinicians must remain vigilant for side effects, including hyperglycemia, hypernatremia, and neuromuscular weakness. Finally, while starting antibiotics is a race against time, managing them requires patience and precision. The urgency of administration is stratified by the severity of the illness. For patients in septic shock or with a high likelihood of sepsis, broad-spectrum antimicrobials must be given immediately, ideally within 1 hour. However, for stable patients where sepsis is only a possibility, a rapid investigation window of up to 3 hours is reasonable to confirm the diagnosis before committing to treatment. Once an organism is identified, daily de-escalation is a crucial component of stewardship. This involves narrowing the antibiotic spectrum and using biomarkers like procalcitonin to guide duration. A drop in procalcitonin of greater than 80% from its peak can signal that it is safe to discontinue antibiotics, a strategy that minimizes side effects and combats the growing threat of antimicrobial resistance.